Hello, everyone, and good morning. Today I'm going to talk to you about headaches in pregnancy. So, this is a TOG article, and it's quite an important one because it's got some very important numbers that time and time keep coming up in your MRCOG exams. So the causes of headache in pregnancy are divided into primary and secondary. So primary is things like migraine and tension headache. Secondary is hypertension, subarachnoid hemorrhage, drug-related example nifedipine, medication overuse, post-dural TAP, meningitis, cerebral venous thrombosis, anemia, caffeine withdrawal, idiopathic intracranial hypertension, stroke, arteriovenous malformation, enlargement of a pituitary tumor, enlargement of a hormone-sensitive tumor, example meningioma, bleeding into a pre-existing tumor, cerebral metastases of choriocarcinoma. So red flag features for potential secondary headaches, thunderclap headaches, so rapid time to peak headache intensity seconds to 5 minutes, example with a subarachnoid hemorrhage. So typically patients with subarachnoid hemorrhage would describe to you that the headache has just suddenly come on, and within seconds to minutes, as this says, the intensity increases. Focal neurological symptoms like limb weakness, aura less than 5 minutes or greater than an hour. Non-focal neurological symptoms like cognitive disturbances, changes in headache frequency, characteristics or associated symptoms, abnormal neurological examination, headache that changes with posture, a sign of high or low cerebral spinal fluid pressure. Headache awakening the patient associated with migraine and raised intracranial pressure, headache precipitated by physical exertion or Valsalva maneuver. Consider subarachnoid hemorrhage or raised intracranial pressure. Patients with risk factors for cerebral venous thrombosis, jaw claudication or visual disturbance associated with giant cell arteritis, especially in women over 50 years. Fever, consider meningitis, neck stiffness, indicative of meningeal irritation, new onset of headache in a patient with a history of HIV infection, new onset headache in a patient with history of cancer. So migraine are common in women, especially during the childbearing age. They're usually unilateral, pulsating. They build up over minutes to hours, associated with nausea, vomiting, sensitivity to light and sound. They can be quite disabling, and they can be aggravated by routine physical activity. Aura can be present for the first time in the pregnancy, which includes things like flickering lights, spots, zigzag lines, tingling, numbness, and visual holds. Symptoms can evolve more than 5 minutes and resolve within 60 minutes. First line is to avoid triggers, rest, get hydration, regular meals, and relaxation. Paracetamol and antiemetics could be helpful to treat symptoms of migraine. However, things like triptans or even non-steroidal anti-inflammatory drugs, especially in the first and the second trimester, can be considered. Triptans cause vasoconstriction and inhibit the release of pain-generating neuropeptides and bind to serotonergic receptors. Um, Sumatriptan is the commonly used triptan, um, and that's something that can also be used in the pregnancy. So if there is 3 to 4 headaches a month, then prophylactic treatment can be considered for migraines. So things like propranolol, 10 to 40 milligrams 3 times a day, amitriptyline, 25 to 50 milligrams at night. There's twofold increased risk of preeclampsia in patients with migraines, 17-fold increased risk of stroke, 4-fold increased risk of acute myocardial infarction in patients with migraines. Idiopathic intracranial hypertension is a rare condition seen in obese women of childbearing age. It's a generalized non-throbbing headache aggravated by anything that increases the abdominal pressure, things like coughing or straining, and associated with diplopia in 38% of cases and visual loss in 31% with papilledema. Diagnosis is elevated cerebrospinal fluid pressure of more than 20 centimeters on lumbar puncture. Management includes monitoring of visual fields and visual acuity because of risk of optic nerve infarction. Um, Advice is to limit weight gain. Treatment with therapeutic lumbar puncture or acetazolamide 500 milligrams BD can be considered. So preeclampsia, so this is a green box talking about diagnostic criteria for headache attributed to preeclampsia or eclampsia. A, headache in a woman who is pregnant or in the puerperium, fulfilling criteria C. B, preeclampsia or eclampsia has been diagnosed. C, evidence of causation demonstrated by at least two of the following. Headache has developed in a temporal relation to the onset of the preeclampsia or eclampsia. Either or both of the following. Headache has significantly worsened in parallel with worsening of the preeclampsia or eclampsia. Headache has significantly improved or resolved in parallel with improvement in or resolution of the preeclampsia or the eclampsia. Number 3, headache has at least two of the following three characteristics. A, it's bilateral. B, it's pulsating quality. And C, it's aggravated by physical activity. D, not better accounted for by any other ICH HD 3 diagnosis. So PRESS is another cause of headache. It's called posterior reversible encephalopathy syndrome. It's associated with preeclampsia. So there's headache, vomiting, visual disturbances, seizures, and altered mental state with radiological findings of edema in the posterior circulation of the brain. Management has to be prompt to avoid the risk of irreversible lesions. So another cause of headache is reversible cerebral vasoconstriction syndrome. So it's a cerebrovascular disorder associated with multifocal arterial constriction and dilation, usually seen in the postpartum period, recurrent sudden onset and severe headaches over 1 to 3 weeks, associated with nausea, vomiting, photophobia, confusion, and blurred vision. Diagnosis requires demonstration of diffuse arterial bleeding on cerebral angiography with resolution within 1 to 3 months. Treatment is with calcium channel blockers, high-dose corticosteroids, and magnesium sulfate. Cerebral venous thrombosis, so commoner increased risk in people who've had cesarean sections, systemic infections, vomiting, and anemia. Greatest risk period is the third trimester and the first 4 weeks postpartum. Incidence during pregnancy and the puerperium is in 1 in 2,500 to 1 in 10,000 deliveries. Thrombosis of the sagittal sinus with secondary extension into the cortical veins or primary thrombosis of one of the cortical veins are the most common sites of involvement in the pregnancy. Thromboprophylaxis should be given at high-risk women, which will help reduce death from PE and cerebral venous thrombosis. Headache is the most frequent symptom present in about 80 to 90% of people. There's also symptoms like papilledema, focal deficits, altered consciousness, seizures, and cranial nerve signs, in particular diplopia caused by sixth nerve palsy that can be seen in these patients. CT would be the first, so if a patient presents with severe headache, CT would be the first line, but it's insensitive for cerebral venous thrombosis, and if you're suspecting that, then an MRI is the choice, is the modality of choice. So it's MRI with T2 weighted imaging and MRV, which is magnetic resonance venography. Refer to neurologists for advice. Treatment is with low molecular weight heparin, at least for 6 months. Um, CVT that's associated with pregnancy and the puerperium tends to have a better outcome and a lower mortality rate. There's some positive in that. This follow-up should be with MRV done at 3 to 6 months, and also refer to hematologists if there's any underlying suspicion of thrombophilia. So, post-dural puncture headache. Puncture of the dura occurs in 0.5 to 2.5% of epidurals. If accidental dural puncture occurs with an epidural needle, there's 70 to 80% chance of a post-dural puncture headache. The headache is usually in the fronto-occipital region and radiates to the neck. It characteristically worsens on standing and typically develops 24 to 48 hours post-puncture. Conservative management includes hydration and simple analgesia. Untreated, the headache typically lasts for 7 to 10 days but can last up to 6 weeks. Epidural blood patch has a 60 to 90% cure rate. So quite important figures in that table. I'll just give you a couple of seconds to just absorb these. So key points on imaging of the headache in pregnancy. The accepted background radiation, accumulated dose of ionizing radiation during pregnancy is 50. Fetal exposure for a CT scan of the head is estimated to be less than 0.005. MRI should be avoided in the first trimester because of potential hazards of hypothermia and acoustic noise, but MRI remains preferable to any studies using ionizing radiation. Contrast media based on the element of iodine should be avoided in pregnancy unless essential. If iodinated contrast media used, the neonatal thyroid function should be checked. Gadolinium-based contrast agents appear to be safe in pregnancy. Lactating women who receive iodinated contrast or gadolinium can continue breastfeeding without interruption. Well, thank you so much for listening. I hope this was useful for you. As I said, it's a very important TOG article, and it's very important to have captured all the different important numbers in from this TOG, and it also goes through the first line management of most things, and also the treatment options for most headaches, which is quite useful even in clinical practice. I please do hit the thumbs up button and subscribe to the channel, and also comment below if there's any particular talks that you are looking for me to do.